Hello everyone. Welcome back to the channel Essentials of Acute, Emergency, and Critical Care. Today we'll discuss tumor lysis syndrome, one of the most important oncologic emergencies encountered in emergency medicine, oncology, nephrology, and intensive care. Although classically associated with chemotherapy, TLS can occur before treatment, after targeted therapy, immunotherapy, or even spontaneously. Delayed recognition can rapidly lead to acute kidney injury, fatal arrhythmias, seizures, and death. In this video, we'll cover pathophysiology, risk factors, Cairo-Bishop diagnostic criteria, clinical manifestations, prevention, and evidence-based management. Let's begin. Tumor lysis syndrome occurs when a large number of malignant cells rupture over a short period. This releases enormous amounts of intracellular contents into the bloodstream. The major released substances include potassium, phosphate, and nucleic acids. The nucleic acids are metabolized sequentially into hypoxanthine, xanthine, and uric acid. The resulting metabolic abnormalities are hyperkalemia, hyperphosphatemia, hyperuricemia, and secondary hypocalcemia. These abnormalities together produce multi-organ complications. Hyperuricemia causes crystal deposition within renal tubules. Hyperphosphatemia combines with calcium to form calcium phosphate crystals, worsening renal injury. Hyperkalemia produces life-threatening cardiac arrhythmias. Hypocalcemia causes tetany, seizures, prolonged QT interval, and cardiac dysfunction. Not every cancer patient develops TLS. High-risk malignancies include hematologic cancers, for example, Burkitt lymphoma, acute lymphoblastic leukemia, acute myeloid leukemia with high blast count, and high-grade non-Hodgkin lymphoma. Increasingly, TLS is also reported in chronic lymphocytic leukemia receiving venetoclax, aggressive lymphomas receiving CAR-T therapy, some rapidly proliferating solid tumors. Patient-related risk factors include high tumor burden, elevated LDH, pre-existing kidney disease, baseline hyperuricemia, dehydration, and high chemosensitivity. Remember, the higher the cell turnover and the faster the treatment response, the greater the TLS risk. Cairo-Bishop criteria. The diagnosis is based on laboratory abnormalities with or without clinical complications. Laboratory tumor lysis syndrome occurs within 3 days before or 7 days after therapy with at least 2 of the following: uric acid greater than or equal to 8 mg per deciliter or a 25% increase. Potassium greater than or equal to 6 millimoles per liter or a 25% increase. Phosphate greater than or equal to 4.5 milligrams per deciliter in adults or a 25% increase. Calcium less than or equal to 7 milligrams per deciliter or a 25% decrease. Clinical TLS. Laboratory TLS plus 1 or more of acute kidney injury, cardiac arrhythmia, sudden death, and seizure. Clinical TLS requires immediate aggressive management. Patients may initially complain of nausea, vomiting, weakness, and muscle cramps. As electrolyte abnormalities worsen, patients develop hyperkalemia as manifested by palpitations, ECG changes, and ventricular arrhythmias. Hypocalcemia as manifested by perioral numbness, tetany, carpopedal spasm, and seizures. Acute kidney injury presents with rising creatinine, oliguria, and fluid overload. In ICU patients, continuous cardiac monitoring is essential because fatal arrhythmias may be the first presentation. Prevention is the most effective treatment. Patients should be stratified into low risk, intermediate risk, and high risk. Preventive measures include: Number 1. Aggressive intravenous hydration. Aim for urine output of approximately 2 milliliters per kilogram per hour. Hydration increases renal perfusion and urinary excretion of uric acid and phosphate. Number 2. Avoid nephrotoxins. Avoid NSAIDs. Limit intravenous contrast when possible. Review nephrotoxic antibiotics. Number 3. Frequent laboratory monitoring. Monitor every 4 to 6 hours in high-risk patients. Management depends on risk and severity. Allopurinol. Allopurinol inhibits xanthine oxidase. It prevents formation of new uric acid but does not remove existing uric acid. Therefore, it is mainly used for prophylaxis, not treatment of established TLS. Rasburicase. Rasburicase converts uric acid into allantoin, which is highly soluble and easily excreted. It rapidly lowers serum uric acid and is preferred in high-risk patients, established syndrome, acute kidney injury, and marked hyperuricemia. Remember, do not use rasburicase in patients with G6PD deficiency because it may cause severe hemolysis and methemoglobinemia. Electrolyte management. Treat hyperkalemia urgently according to ACLS protocols. Avoid routine calcium administration unless the patient has severe symptomatic hypocalcemia, seizures, or life-threatening arrhythmias. This is because additional calcium may increase calcium phosphate precipitation. Use phosphate binders when indicated. Renal replacement therapy. Dialysis should not be delayed when there is refractory hyperkalemia, severe hyperphosphatemia, symptomatic hypocalcemia, severe metabolic acidosis, fluid overload, and progressive acute kidney injury. Continuous renal replacement therapy is often preferred in hemodynamically unstable ICU patients. Let's summarize today's discussion. Tumor Lysis Syndrome is a preventable oncologic emergency. Early identification of high-risk patients is critical. Hyperkalemia is usually the most immediately life-threatening abnormality. Aggressive hydration is the cornerstone of prevention. Allopurinol prevents uric acid formation, whereas rasburicase rapidly removes existing uric acid. Early ICU involvement and dialysis can be life-saving in severe cases. Thank you for watching. If you found this video useful, please like, share, and subscribe to the channel. Let me know in the comments which oncologic emergency you would like me to cover next. See you in the next video. Stay safe and keep learning.